MedCram.com.
If your heart stops, do you want us to do everything? That's what you might hear if you get admitted to the hospital when they're going over your code status. Hi, I'm Dr. Roger Schwelt, and welcome to another MedCram video. Today we're going to talk about CPR, whether or not it is worth the risks of CPR. Now, this may sound provocative, but there are a lot of misconceptions about what CPR can and cannot do, and today we're going to talk about it. And there's an interesting article that was put out by Clay Dalton titled, "A Natural Death May Be Preferable for Many Than Enduring CPR." Many of us know what CPR is. It's cardiopulmonary resuscitation. It came out in a paper. This was an article that was published in July of 1960, and this paper was published in the Journal of the American Medical Association titled Closed Chest Cardiac Massage. Prior up to that time, what they would do is actually do open thoracotomy and direct cardiac massage. And it wasn't until they actually tried this in animals and then in humans that they found that actually there could be some usefulness to doing external thoracic cardiopulmonary resuscitation. They say here, as a result of exhaustive animal experimentation, a method of external transthoracic cardiac massage has been developed. Immediate resuscitative measures can now be initiated to give not only mouth-to-nose artificial respiration, but also adequate cardiac massage without thoracotomy. The use of this technique on 20 patients has given an overall permanent survival rate of 70%. Anyone, anywhere can now initiate cardiac resuscitative procedures. All that is needed are two hands. We're going to talk about this 70% in just a bit. But it seems as though there was some, at least initial, indications of significant benefit to closed chest cardiac massage back in the 1960s. The heart is in the middle of the chest and it's surrounded by ribs. We call this area up here the base of the heart, and this area right here is the apex of the heart. And when we do chest compressions, we're putting our hands here and we're pushing in and doing chest compressions. And generally speaking, we need to go in about 2 to 2.4 inches deep with each compression. And each compression should be at around 100 to 120 compressions per minute. And generally speaking, we should switch off every 2 minutes because it's actually quite demanding. Recently, there's been a lot of campaigns to get people to understand. And as it turns out, one of the songs from the Bee Gees back in the 70s is called Stayin' Alive, and it actually happens to be right around 104 beats per minute. So it's right in that 100 to 120 per minute. So sometimes they'll play that song as they're teaching you how to do CPR. What I found really interesting is that about 155 in the piece, it comes to the part where you're supposed to switch off, and it's kind of interesting because the lyrics at that point in the song are "Somebody help me," which is appropriate, I think. Speaking of pop culture, it's interesting to note what the general public thinks about CPR. This is important because when patients come into the hospital and we ask them if they would like us to do chest compressions, this is what they have in mind. So if we look at the literature, they actually did a study where they looked at two popular television shows, Grey's Anatomy and House, and they looked at the episodes from 2010 to 2011, and they wanted to look to see what was the pervasive idea about what happened to patients in whom CPR was started. They looked at 91 episodes in this study, and there was 46 times that CPR was started. And the survival rate, interestingly, was right around what was published in 1960, which is about 69.6%. Of those people that received and survived after CPR, 72% went on to survive the episode, whereas 16% died before the end of the episode. The other ones, I guess, were unknown. But you can see clearly here that at least the Hollywood version of CPR shows this to be a beneficial and survivable procedure. Why wouldn't anyone want to have this done? In fact, when they asked people who had to be in charge of decision-making for ICU patients, people that we call surrogates, they looked at a study here titled, "What CPR Means to Surrogate Decision Makers of ICU Patients." And when they asked these surrogates, and it was about 50 of them, to make decisions on admitted patients to the ICU within 24 hours, they found that the majority, or 72%, believed that survival after CPR was greater than 75%. Kind of on par with that original paper and also what they saw on television. As it turns out, the results are far more dismal. So this paper looked at CPR. It was published back in 2010, titled Predictors of Survival from Out-of-Hospital Cardiac Arrest, a systematic review and meta-analysis. And what they did was they looked at 79 studies involving almost 150,000 subjects. And the pooled survival rate to hospital admission, so this is outside of the hospital, coming to the hospital, was only about 24%. And hospital discharge was only 7.6%, and that literally has not changed in about 3 decades. So what was the chances of somebody getting cardiac arrest, needing CPR, going to the hospital, and actually being discharged home? It was only 7.6%. Now, this is out of hospital arrest, okay? This is not in the hospital. So what improved your chances of making it to discharge? If there was a bystander, you went from 6.4 to 13.5%. If it was witnessed by EMS, you jumped up to 18.2%. If there was a bystander that was doing CPR, went up to 16.1%. If you're found to be in ventricular fibrillation or ventricular tachycardia, that's something that we call is a shockable rhythm, you went up to 23%. And if there was spontaneous circulation that was achieved, otherwise known as return of spontaneous circulation or ROSC, it went as high as 33.6%. But what about in-hospital cardiac arrest? So this is important because this is the data that you would need to know when a physician or a healthcare provider is coming up to you in the hospital and asking you, if your heart were to stop, would you want us to do everything? Now, it's kind of a bad way of asking that question because who wouldn't want you to do everything? But what they really ought to be asking you is, do you want us to get onto your chest and compress it to the point where we might break ribs? We'll talk more about that. So here was a study that looked at in-hospital cardiac arrest, over 84,000. And what they found is that from 2000, which is the year I graduated from medical school, into 2009, which is when I was just out into working after my fellowship and trained in critical care medicine, the risk-adjusted rates of survival to discharge went from about 14% all the way up to 22%. And they said here that rates of clinically significant neurological disability among survivors decreased over time with a risk-adjusted rate of 33% in 2000 and 28% in 2009. But this is still something that is considerable. So think about it. Even though they may survive, those abysmal rates that we looked at before, remember that almost a third of them are going to suffer some sort of permanent neurological damage because not enough blood is getting to their brains. If we look at long-term outcomes after in-hospital CPR in older adults, so let's say we have somebody who's an older adult and they have a chronic illness, and they come into the hospital and the doctor says, we can do chest compressions, or they might just ask, if your heart were to stop, do you want us to do everything? And of course, the temptation is, of course you want to do everything. But what they really ought to be asking you is, do you want us to do chest compressions? You can see here for COPD, people with severe COPD are going to have lower survival rates. Same with CHF. Over these amounts of months, CKD over these amounts of months, people with malignancy, it's going to be lower survival rates for CPR. Diabetes, it's also lower, and then finally cirrhosis is also lower. So if we're looking at a year, we're looking at, for COPD, somewhere between 25 and 50% 1-year survival. So the efficacy may not be as good as we might think from pop culture, but what about the risks? What are the complications of CPR? Because the heart is sitting in the middle of the chest and we're doing chest compressions directly on it, you could get broken ribs. Now, those broken ribs can cut into the lung tissue below and cause a popping of that lung and air to escape around the lung, and that's known as a pneumothorax. Also, obviously, you could have a pulmonary hemorrhage from those ribs getting inside and tearing tissue. But a more scary side effect potentially is that you're actually successful in chest compressions and you're going to restore blood flow to the brain. And while the patient might have been unconscious when you arrive, that when you start doing chest compressions, they actually may regain consciousness. And that might be as the tube is going down into the throat and you're putting IVs in and you're doing chest compressions and breaking ribs. So the question is CPR something that we ought to be doing at that point? And obviously that's a discussion that you want to have before they get to this point so that everyone can be clear on it. Obviously, if the patient is a full code and they do code, then doing CPR is probably the right idea. One of the things that I have learned in doing CPR is that ribs do break, especially here on the left side. And because they can cause jagged indentations into the lung, you really have to be concerned about a pneumothorax. So what I like to use is lung ultrasound right at the bed, because if you're waiting for the patient to develop symptoms of a pneumothorax, or you're waiting for the chest x-ray to be done, sometimes that can be so long and you need to know right away. Let me show you how that works. By putting the lung ultrasound probe here on the rib cage in between so you can see the lungs, you will see a lining that lines the inside of the pleura, and then you will see the lung, and that lung will be everything on this side. And because the lung is inflating and deflating, you'll see that these two surfaces start to rub past one another. And what you'll see there is something called lung sliding. Let me demonstrate that for you. Here on the left-hand side is the real-time image. We see here the ribs, and this is the very important part right here. This is where the parietal pleura and the visceral pleura are rubbing up against each other. Let's erase all of that there so you can take a look. And you can see as it is rubbing up against one another, you see movement that gets reflected all the way down below. So let's take a look at that one more time. And notice that because it gets reflected down below, when we put this on a timed mode where you're looking at it across time, you'll see that this looks very heterogeneous down below, whereas up here you see lines going across. The reason why you see lines going across is that nothing is changing here in the upper portion, but there is lung sliding here at this point, and as a result, everything changes here. And so that's why you get this kind of sandy beach here. And here you have waves coming into the beach. So a sandy beach with waves coming in means lung sliding, means no pneumothorax. Let's take a look now at a pneumothorax. This is where you have no lung sliding. What you'll see here is that this area has no lung sliding, nothing gets reflected down below, and so you have these lines going across. And in fact, lines are going across everywhere. This is known as the barcode sign. So let's take a look at that in motion. And you can see here that as this goes forward, there's nothing really moving down here, so this is the barcode sign. If you don't see lung sliding, that doesn't necessarily mean there is a pneumothorax, but it's highly suggestive, as there can be other things that could do it as well. If there is lung sliding, then you know at least in that place, right there at that moment, there is no pneumothorax in that part of the lung. You can learn more about this with our MedCram course on lung ultrasound, explained clearly. And that's over at medcram.com. We'll put a link in the description below to that. The question is a natural death preferable for many than enduring CPR? Because if there is a pneumothorax, then I've got to quickly make an incision in the skin, get down between the ribs, and pop a chest tube into there to evacuate all that air that's around the lung. They say the true purpose of CPR is to bridge the person to an intervention. Jason Tanguay, an emergency physician, told the author of this paper, Clay Dalton, if they can't get it or there isn't one, then what is it accomplishing? This is the crucial insight that doctors have and most others don't. CPR is a bridge, nothing more. Sometimes it spans the distance between life and death, if the cause can be quickly reversed, and if the patient is fairly young and relatively healthy. But for many, that distance is too great. The act of resuscitation itself cannot be expected to cure the inciting disease, the Hopkins researchers wrote in 1961. So what really needs to happen is a detailed, patient-centered, and informed discussion on DNR and code status. And we've actually put together a video for that that's available on medcram.com, also here on YouTube. And we'll put a link to that description below as well. There's a number of different ultrasound courses that we offer at medcram.com, not just the lung ultrasound course here, but the FAST exam, lung ultrasound in COVID-19, and also principles and instrumentation of ultrasonography. And this is put together by our resident ultrasound expert, Dr. Joshua Jaquette, who is an emergency room physician. So this is a discussion that we often have with patients in the intensive care unit that are coming in. Obviously, the ultimate decision rests with the patient or their surrogate, but realize that if the patient's heart is stopping and it needs resuscitation, there is usually a good reason in the intensive care unit that someone's heart is stopping. And it means that all of the medication that we're giving non-invasively hasn't worked to this point. And if we're going to be doing invasive chest compressions to get the patient back, we're going to need to change the underlying condition. And if we've done everything up to that point and the underlying condition has not changed, then the chances that CPR is going to do something beneficial is pretty low. So I hope that's been helpful in the discussion of CPR. Give us a thumbs up, subscribe, turn on notifications, and join us at medcram.com.